Hello doctor, today we are discussing the management of COPD regarding NIC guidelines. First of all, you have to generally manage the patient with advice of smoking cessations along with annually giving up just one injection of influenza vaccination along with every 5 years having a pneumococcal vaccinations. As you know, why we are giving the influenza and pneumococcal vaccination, because COPD is the mild immunocompromised condition. That's why we give all those patients that are immunocompromised, we are giving influenza yearly and pneumococcal every 5 years. Or patient have a history of splenectomy, autosplenectomy, or splenic dysfunction. Then we are going to use the bronchodilator therapy. First of all, you have to use the short-acting beta-2 agonist or short-acting muscarinic antagonist as a first-line therapy. If the patient remains breathlessness or patient having exacerbations, then you have to, first of all, you have to check the forced expiratory volume V1. If patient having a stage 1 or 2 having a forced expiratory volume, how to check the forced expiratory volume V1, first of all you have to check the bronchodilator is given, then the ratio is checked of forced expiratory volume 1 to forced vital capacity. If these ratio is less than 0.7, this is the obstructive pattern, then you have to do the forced expiratory volume 1 in 1 second. If it is predicted value is more than 80%, then it is stage 1. If it is more than 50%, it's a stage 2. 50 to 79%, stage 2 are moderate conditions of COPD. If the patient having ratio is less than 50%, like this is between the 30 and 49%, is a stage 3 or severe, and if less than 30% of predictive value, then it is very severe condition, is a stage 4. So we are discussing here for the management. So if the forced expiratory volume Y1 is more than 50%, then it is in the stage 1 or 2. Then you have to first start the long-acting beta-2 agonist salmeterol or long-acting muscarinic antagonist like a tiotropium bromide. But you have to check first if patient having a ischemic heart disease or CVA history of, then you have to use this long-acting muscarinic antagonist with cautions. If the patient having a forced expiratory volume V1 is less than 50%, like a stage 3, stage 4, severe or very severe stage, then you have to use the long-acting beta-2 agonist along with inhaled corticosteroids. If or you can use just only a long-acting muscarinic antagonist. If the patient having a condition persistent exacerbation or breathlessness, then you have to add the long-acting beta agonist with inhaled corticosteroid combination therapy. If it is not improved, then you have to add all three: long-acting muscarinic antagonist, long-acting beta agonist, and inhaled corticosteroid. But if patient have a history of CVA, then you have to use with cautions regarding the long-acting muscarinic antagonist. Along with you have to do the pulmonary rehabilitation therapy. Thanks for watching.